Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon. Today we're going to be talking about lung cancer screening, who should be screened, what the current guidelines are, and some additional considerations. Joining me today are Heidi Onda and Lauren Groner. Maybe you both can explain your connection to lung cancer screening and why you wanted to come join today.
Yes, so I am a 7-year lung cancer survivor, just diagnosed with stage 3A inoperable lung cancer. And I started the White Ribbon Project in the fall of 2020 to increase lung cancer awareness and help people understand that anyone can get lung cancer. No one deserves it. And there's great hope today, even in a late stage diagnosis. So we want you to get screened.
Love it.
I love that. Yes. Thank you, Heidi. Thank you for spreading the good word. My name is Lauren Groner. I am a cardiothoracic radiologist. That means I am a radiologist who specializes in heart and lung imaging. And I also am a health services researcher. My main focus is on coming up with novel strategies to improve the uptake of lung cancer screening in various settings. So I love lung cancer screening. This is near and dear to my heart. I lost someone very special to me to a lung cancer diagnosis. And now we've come so far since then. So I just want people to use this tool that we have and is so underutilized.
Yeah, I couldn't agree more. We have the great tools out there, and we don't have nearly as much intake, I guess, with people using them. And that led to a big part of that led to the White Ribbon Project. Heidi, can you speak a little bit to what inspired that movement?
Yeah, so I became very frustrated, and so did my husband, who's now he's a retired primary care physician. That given that lung cancer is the number one cancer killer of both men and women, why didn't we know that anyone could get it? Given our backgrounds, him a primary care and me a health educator, and when approaching cancer centers across the country, other advocates reporting back that there were really no plans for Lung Cancer Awareness Month, which comes up in November. I just became very frustrated and thought, I can start from my own front door. And I asked Pierre to please make me a big white ribbon out of wood that I could scream from the front door that I had lung cancer, I wasn't ashamed of it, and we need to talk about it. One picture on social media went viral, and before we knew it, the whole country wanted these ribbons, which we have supplied the best we can, and now 36 countries as well.
No, it's amazing. And I think we were mentioning that anyone can get lung cancer, but we have certain indications around who will screen for lung cancer. And what we mean when we say that is if someone doesn't have symptoms, we're just going to check anyway. This is similar to women with mammography is probably the most commonly known screening tool for a cancer. Colonoscopy, similar. In lung, we have the low-dose lung CT. Lauren, can you explain a little bit about what the low-dose lung CT is?
Yeah, I thought you'd never ask, Kyle. So a low-dose CAT scan or a low-dose CT is it's a CAT scan. It is a low radiation dose CAT scan. What is radiation? Well, every day actually we're exposed to radiation just by living on planet Earth. You get around 3 what we call millisieverts. And what's probably easier is to compare it to something like mammography, where the amount of radiation in a low radiation dose CAT scan is the same as a few mammograms, right? So it's much lower, about 7 times lower than the average CAT scan dose. And these are really just X-rays that take pictures that create a 3-dimensional image of your body. And typically it'll scan from your lower neck where your thyroid is to your upper abdomen. So that's what's great about lung screening is we find, we can look for lung cancer, but we can also look for other things that are important. Like we can look at your heart vessels and we can look at other organs and we can detect things that may otherwise go undetected.
Well, I'm really happy you picked up or you mentioned the element of radiation dose with the low dose lung CT. And that's what we mean, I guess, when we say low dose, is there's not a lot of radiation there. But I do know that there are people who are worried about the radiation they get from their scan. Does that lead to other cancers? Can you speak a little bit to the effect of the scanning radiation on someone's risk of developing a cancer?
Yeah, I think this is something that actually came up pretty recently, right? There was a study that was done that showed that, getting a CT can increase your risk of cancer by up, or that CTs are responsible for around 5% of cancers, or it was something like that. And it raised a lot of alarm bells. I think one thing that I always tell people with regard to lung cancer screening is if you are eligible, then there is a net benefit to you getting screened. And with everything in medicine, of course, there's a risk versus benefit, and we always have to weigh the risks and the benefits. And of course, you should always do something if it's a benefit to you, right? In terms of the age group, it's, these are folks who are 50 to 80 years old. This is something that is low radiation dose that you're getting theoretically annually. And so I think just given the age range and the amount of the dose, it's really negligible. And this is something that is not as much of a concern anymore, just based on current data and, now the benefits that have been shown by multiple trials, including 2 large randomized control trials. And for, some of our audience who doesn't, who they're not as engaged in research, randomized control trials are sort of like the gold standard of a research study. And there are 2 large randomized controlled trials. One is a US-based trial called the National Lung Screening Trial that was published first in 2011. And then in 2019, there was a Dutch-based trial called the Nelson trial that also showed a mortality benefit to lung cancer screening. And what that means is that it showed that lung cancer screening with low-dose CT specifically decreases your chances of dying from lung cancer. And it actually showed the NLST trial, or National Lung Screening Trial, showed that it improves all-cause mortality. So it lowers your chances of dying from any cause. And I think that's because it can detect things like coronary artery disease or heart disease, is probably a more friendly term for all of our audience. It can detect things that are significant that may otherwise go undetected.
And you mentioned an age criteria.
Mm-hmm.
Above the age of 50 is usually where we start. Are there any other recommendations or requirements that someone must need?
Yeah, good question. So, lung cancer screening is different from other cancer screenings, right? Typically, to get screened for whatever cancer, there's typically an age cutoff, right? Of course, with breast cancer screening, it is also usually women, although men can get screened. Typically, they present if they have a lump or some abnormality. But for lung cancer screening, it's a little trickier because it's actually based on your smoking history. So, insurance companies, of course, we're all kind of beholden to insurance companies, really only recognize 2 guidelines. And those are the United States Preventive Services Task Force guidelines and the Centers for Medicare and Medicaid guidelines. So that's CMS. And they're very similar. They're actually identical except for an upper age range. So to be eligible for lung cancer screening, you have to be between the ages of 50 and 80 years old. You have to have smoked at least 20 pack years. Your pack years are the number of packs you've smoked per day times the number of years you've been smoking, and either currently smoke or quit within the past 15 years. So the only difference between the USPSTF guidelines and CMS is that for CMS, it's between 50 and 77 years of age.
Okay. So, hopefully those listening, if you fit within this category, we're going to talk more about where you can go to learn more about your lung cancer screening. But we're talking about this being a CAT scan. There are many ways one could be screened for cancer. The one we do for lung cancer is a CAT scan. Heidi, could you speak a little bit to the process of having a CAT scan done?
So I think the process of the CAT scans that I get done is a little bit different than a lung cancer screening CAT scan. I don't believe that there's any contrast dye involved with a low-dose CT scan for screening purposes. I think you lie down. I lie down on a bed, and I'm in a little tube like a donut, very comfortable with my arms over my head. And then the scanner starts, and it's about 2 to 3 minutes, and then you are pushed out of the tube by the bed as on, I guess, rollers, and then you come up and you're done. When you have lung cancer, it's a different story. You have to deal with, an injection and so forth. But this is a really simple, easy test, non-invasive. You don't have to disrobe, and you can be proactive in your health.
Couldn't have said it better myself. Yeah.
Yeah, I think it's great. And this is a modality that this type of imaging is something that you really champion with the White Ribbon Project. Can you speak to your personal connection? Why push that?
Yeah, so I am not eligible for screening, and I wasn't eligible for screening 7 years ago. And probably will never, well, I'm screening for life now to surveil a lung cancer. And I want people to have this opportunity, if they're eligible for, to catch it early. It's a simple test. And there's so much hope now, even in a late stage diagnosis. So you do want to know. So it's not the scary images that we're used to seeing that institutional messaging has been putting out for about 60 years. It's a whole different perception of this disease. So if you were to, have a scan, if you qualified with all of the eligibility criteria that Dr. Groner talked about, you would get the scan. And if you're caught early, you could probably be cured or just have more surveillance, surgery, radiation. There's lots of treatment options. And if you happen to get caught late, like me, look, I'm 7 years out. I'm living a high quality life. You want to know.
Yeah, I think I couldn't have said it better. And catching cancers early is really the key to having better outcomes in curing. I'm in the research field. I work on therapies that mostly go throughout the body once someone becomes metastatic. But once someone becomes metastatic, meaning the cancer has developed the ability to spread throughout the body, and if it started in the lung, it can then go to the liver, it can go to the brain. Once that happens, the likelihood we're going to be able to cure someone is really low. So still, we really rely on my colleagues. I'm a medical oncologist. We rely on the surgical oncologists, the radiation oncologists, people who deliver stuff locally to the tumor. Like if it stays in the lung, they can cut it out. They can radiate it. Once it's left the lung and it goes to everywhere else, and you're seeing me for treatments that go everywhere, it's really hard to cure. We have a lot of good treatments, and there's a lot of good therapies out there that can make people feel good and decrease their symptoms and help them live longer. But, our goal is cures. And screening right now, I believe, even though I work in a research field for people who are metastatic, screening is where we're going to get the most bang for our buck in terms of cures, longer lives lived. And then, with the low barrier, really, of a low dose lung CT, which isn't that intrusive, you can get this cut out, get it radiated, and get on with your life. There's still additional considerations, but it's a very different field than once you become metastatic.
Yes, but because of the good work that you're doing and your teams are doing across the country and around the globe, people who are caught late stage are still there. They will not be cured, but they could have long-term manageable conditions where they can still have a high quality of life. So still worth getting screened, even if you're concerned that, well, what if it's later stage? Still lots of hope.
Well, and you can get that initial screening, and then you're probably not done. So just because you have an elevated risk of lung cancer and you get the initial screen and it might be negative, meaning we don't see any evidence of cancer there, that doesn't mean your risk is zero now. So Lauren, can you speak a little bit to the frequency or how often someone should undergo low dose lung CT if they're eligible?
Yeah. So for people who are eligible, you should get screened every 12 months. You can kind of think of this as like really part of your annual wellness exam, because the whole point is you want to screen when you feel well, right? That is the time to get screened. And I think that can be confusing for people, right? You're like, I don't have a cough. I don't feel bad. I feel great. I don't need this test. I don't have cancer. And the thing is, you don't know. And if you get screened and you just get checked and you make sure everything's okay, if we find something, most likely it is going to be early stage and it's going to be treatable and potentially curable. So, I'm like you, Heidi. I want to know it, I want, because now we have so many treatment options, and getting screened with low dose CT screening every year is really your best chance at living a lung cancer free life.
And Heidi, what do you think are some of the reasons people don't undergo screening if they're eligible?
I think many people don't know about screening. I think many doctors are dealing with a lot, and there is a lot of criterion to sift through to figure out if somebody is eligible, and that sometimes slips through the cracks. So they're not being told by mass media that there's lung cancer screening, number one. So they don't have that awareness because most women know to advocate for their mammograms. We don't have people coming in asking for their lung cancer screening. Many doctors are not, or their care teams are not referring them, so they don't know. And then I think there are a lot of people who are really scared to find out that they are, believing these images that are really outdated now and need to be modernized, and understand that the perception of lung cancer is totally different now. I mean, I'm a late stage lung cancer patient, 7 years out. Nothing's getting in my way to live my life right now. So,
Yeah, and
go for it.
I can tell you, I come from a family of heavy smokers, and there was very much this belief that if I got lung cancer, I'm just not going to do anything because I don't, that's it. If I get it, I get it. And there's not a whole lot of utility to screening. Like, why would you screen if you find this thing and you can't do anything about it? Which I would get if that were true. And I think, years ago, that outlook was probably even a little more appropriate.
Mhm.
Like, we only had heavy dose chemotherapies. They don't work that well when used alone. But now we have things like immunotherapy. We have better techniques to remove tumors entirely. We have targeted therapies. We have all these things. And if someone's diagnosed with a lung cancer today, it looks a lot different than it was 40 years ago, 30 years ago, even 20 years ago.
Absolutely. And I think the physician education needs to catch up to that too. Our primary care teams and even pulmonologists. I mean, I was diagnosed over the phone, given that prognosis over the phone by a specialist I never had to see in my life, never even met, a pulmonologist who didn't really know about the advancements and treatments, and basically told me I had 4 to 6 months to live. Get your affairs in order would be a good idea for you. And that still resonates 7 years out, that's what I was told. My hope is that newly diagnosed 7 years later, there's better information out there for our healthcare teams to deliver this information in a more hopeful manner, because there are many more options than there were, let's say, 10, 15 years ago.
Well, and building on your point, I had a family member who was diagnosed last year with metastatic lung cancer, and they were diagnosed in a rural area that wasn't as up to date on the recent advancements. And my family member was lucky enough to have a mutation in their tumor. That's something we can recently do something about. We have targeted therapies for it, which work very well, but they didn't know that. And I wouldn't necessarily expect them to. They don't work in that field. But the message was very clear that it was, we're not sure you're going to be alive in 3 months, which is really devastating, of course, for anyone to hear. And it was really hard for me, because then I had to work on this uphill emotional battle to say, no, there really is hope. And then, got them to a large center that specializes in that type of thing. And they're doing great.
Yeah.
Like, really, the tumors shrink down. They're on these new therapies, minimal symptoms, and they're back to living a high quality of life. But that perception is ubiquitous even throughout the healthcare community, just because this stuff is moving so fast.
Yes.
I think that's why these conversations are so important, because we need to really be clear that the message and the natural history of lung cancer, the message around that needs to change. It has changed. Lung cancer is treatable. I mean, and potentially curable. And doctors need to know that. Care providers of all kinds need to know that. Patients, their families need to know that, because this is something that should be front of mind, because it is treatable and it is potentially curable. And so if we can start thinking about this in the way that people think about colorectal cancer screening and breast cancer screening, and just normalize this and be bringing this up all the time in conversation wherever we are, whether it's in Heidi's living room or it's in a doctor's office, I think that's how we're really going to get this word out. And people won't have that same fear around lung cancer, which is so disproportionate to what we see with other cancers, because people just don't know how much things have changed, right?
Yeah, and the stigma, to your point, that lung cancer is associated with smoking, which is true. The majority of lung cancers still do occur from tobacco being the risk factor. People inhale tobacco, it causes mutations, a lot of inflammation. and that can lead to lung cancers. That's not the only thing that leads to lung cancers, though. Right now, it's what screening is framed around because we have the best data around it. But I think there's a lot of advancements in multiple areas of lung cancer, and there's a lot of room for optimism. So for the individual who's worried about getting screened, because what are you going to do about it? Like, I'm just going to have this death sentence if it's positive, so it might as well not even bother. I think we need to challenge that. But that being said, with every test, there's pros and cons. Lauren, can you speak a little bit to a downside of lung CTs?
Yeah, I mean, so I do want to reiterate, and I am a fan of screening in case you have not noticed. And I do want to reiterate that, of course, every test has downsides, but really, if you are eligible, there is a net benefit to you getting this test. I mean, really, I tell my family members, my friends, I had been working on a family member who was eligible for the past, I won't even tell you how many years. She finally got screened. Feels so much better. They did find some plaque in her coronary arteries. She's on a statin now. She doesn't have lung cancer and she feels better and she's getting the treatment that she needs for other areas of her health. But so we talked a little bit about radiation, which, in my opinion, is pretty negligible just based on the amount of radiation and the age range at which people are eligible for screening. A lot of screening tests, you talk about false positives. This is really important. I think we have standardized nomenclature and guidelines around lung cancer screening for radiologists. We follow what it's called lung rads. And these are guidelines that guide us as radiologists that based on the size of a nodule, based on it, how it looks, it's whether it's solid or it's ground glass, so that's the density, where it is, where it's located. These are all things that can tell us how suspicious this nodule might be. And then it will also tell us what the management should be based on that score. So if you follow lung rads, then the false positive rate is very low. And what I mean by that is there are two different kinds of false positives you can think about. Sometimes you can just have a totally negative exam, meaning you have nodules that I think are benign, based on its size, based on the way that they look, or maybe you have no nodules at all. And that's considered a negative exam, and you just get another screener in 12 months. And then there are exams that are inconclusive. I won't get into all of this, but maybe you were breathing during the exam, and so we need to call you back for more images. Maybe you had another scan, and we would need those images uploaded so I can compare. Maybe you have pneumonia or some other thing that I think is inflammatory, and I want you to come back in a few months. So that's kind of the inconclusive category. And then there's the positive category, and that can mean there is something that I see, a nodule, and I know we've talked about this in a prior episode, but for folks who don't really know what nodules are, you can think of these as like freckles and moles on your skin, right? That everyone has them, or most people do. Most of them are benign. And so these are the same thing. They're little spots on your lungs, and most of them are benign. But sometimes, based on the size, based on the way that it looks, I want to call you back sooner than 12 months. Usually that would be the case, that I would recommend a follow-up in 3 or 6 months. Very, very rarely, I will recommend a biopsy or a PET scan. And that's because I think it's suspicious enough. But the false positive rate in terms of calling you back a little bit sooner, I think, in my opinion, and Heidi, I would love your opinion on this. I think that's pretty different than sticking a needle into somebody's lung or biopsying something, right? It's just to make sure that something doesn't change or grow. And if it does, okay, then you go on to the next step, and probably waiting that short amount of time, it gives us some more information about what this nodule is. And so in terms of the false positive rate, the false biopsy rate is very low. If I'm sending someone for a biopsy, I'm really, really sure that this is cancer. Nothing in medicine's 100%, but it's pretty darn close when I'm sending somebody for a biopsy. So that's kind of in general. And then I guess the last one, of course, and as somebody who's been on the receiving end of this, I got my first mammogram this year, and, it was abnormal. They had to call me back for diagnostics, and you're kind of waiting for the results, and you go and you're like, I'm young, I'm going to be fine. And so then you get these tests and you're waiting, and there is some anxiety that comes with that. Just something you kind of can't prevent. So that's probably the last thing, right? Is there's always going to be some anxiety around waiting for your test results and being worried. But at the end of the day, this test is really meant to just check and make sure everything's okay. Most of these tests are going to be normal or negative. But when we do find something, it's important to kind of face it head on.
Well, and when you use the terms false negative, false biopsy, what do you mean when you say that?
Yeah, so it means essentially that, so a false positive, I guess, would be I see a nodule that because it is of a certain size or looks a certain way, I can't say it's for sure benign. So I call you back for a sooner scan, or I recommend another test. And it turns out that this is based on those follow-up scans. It's probably still negative, meaning it's probably benign. That would theoretically be a false positive, right? Because it's something that I thought was suspicious and ended up not being suspicious. A false biopsy, which, I think is sort of a category in and of its own, is when I think something is suspicious and the biopsy tells me it is not. This is not cancer. And that's where I really want to reiterate that it is pretty rare for us to send someone for a biopsy and it turn out to be not cancer. And so I want people to understand that. And again, I think this gets back to what I always tell people, which is if you have questions, if you think something's confusing, if you want to know more, please reach out to the radiologist. I think we're always so happy to explain what these findings mean and what these different terms mean. And everybody's different. Everyone has their own threshold for how much or little they want to know. But sometimes patients do just want to talk to the radiologist, right? And not go through a middle person, not go through their provider. And I think knowing that you can do that and having agency and advocating for yourself is so important. I do it as a patient.
Mm-hmm.
Yeah, and following up on that, the principle where there's something that we're worried is cancer, we do a biopsy, and it's negative, meaning it doesn't look like cancer in the biopsy. There's a lot of anxiety, appropriately so, in that situation. And it's something we've actually talked about in the podcast before. So I'm curious to hear your thoughts. For a patient who had a concerning scan and got a biopsy that didn't reveal cancer, what are their options? What are ways we typically go forward?
Yeah, so I think it depends. It depends on a lot of different things, on the characteristics. I think typically what would happen is the person would get a follow-up scan. There have been times where somebody gets a follow-up scan or they get a PET scan, right? There are lesions that don't always light up on a PET scan because they can be very, very slow growing cancers. And in those cases, and they've had a biopsy that said this is not cancer, and I'll say, look, I think this is something that has grown. It doesn't light up. It has suspicious features. And in my opinion, I still think this is cancer. And I'm usually right. I mean, look, I make a lot of mistakes, folks. Okay. But no, I mean, in general, when you really kind of take all of the information that you have at your fingertips and you look at the behavior and you look at the different imaging features, and as a radiologist, my job is to be the expert. And so sometimes biopsies are wrong, tissue can be wrong, right? And that's why these multidisciplinary discussions are so important. And everybody should be weighing in. And I think it's important to know when to challenge those diagnoses. Yeah. And then, look, if you're wrong, admitting you're wrong, and that's okay. And you learn from those mistakes.
Yeah, that was my sentiment as well. Biopsies are wrong sometimes too.
Yeah.
And for those, if we proceed to a biopsy after a scan, like a low-dose lung CT, what we're doing is we're inserting a needle either through, we'll use a bronchoscope, a scope that goes through the mouth and the trachea, and we'll get a piece of the lung tissue. But, you're navigating that in real time. The person's breathing. You're, trying to get this area in three-dimensional space while the lungs are moving. Or you're going from the outside and you're having a needle go through the skin into the lung. Again, it's, usually guided in a way, like we'll use imaging to assist that to try to get it really right. But it's not the easiest task. So sometimes those are just blatantly wrong. You missed it. Or you got something that looks, similar. There's some inflammation there. Can't really tell. So they're not perfect. And sometimes the answer is, hey, we got to try again.
Yeah.
And as a patient, if you have your scan and you're really worried, but it comes back benign, meaning we don't see cancer there, it's appropriate to push back a little bit and really raise that and say, hey, did we miss it? Or do you trust this finding? What are we going to do? Because, I could see situations with clinics that are very busy.
Mm-hmm.
It comes back benign. The provider is reassured. And then we wait till next year. When in reality, it was a false negative, meaning there was cancer there really, but the biopsy missed it.
Yeah.
I'm curious, Heidi, as you champion the White Ribbon Project, are you seeing more people who are getting these low dose lung CTs, and what are the experiences they're having?
So we have my husband as a primary care physician is very passionate about lung cancer screening. He knows how pressed he was for time. He knows he could have done better. He's now developing tools to help teach primary care how to navigate this. And in rural Southeast Kansas, we actually have data that we've had an impact.
Yeah.
And so Pierre wrote for a grant and was able to get collaboration between a lung cancer advocacy organization, the university academic center, a lot of players coming into the table for the same goal to better outcomes. And we were able to get billboards up with a 800 number for people to call, and it basically just had, are you between the ages of 50 and 80? You could be eligible for lung cancer screening. And then there was the phone number, and then apparently the switchboards were lighting up. Part of this funding also helped to give some education to primary care, and it was a very short amount of time that the screening rates tripled.
Yeah.
I don't know how many positives or negatives came out of it, but we just know more people were getting screened. And personally, again, this is very anecdotal. I don't see why we can't replicate this throughout the rest of the country to get this on people's radar. I think one of the other issues is, though, which I see in the community, and I represent that as well, somebody who was not eligible.
Yeah.
There's a lot of anger out there. How do we get screened? How do we get our loved ones screened? Perhaps this is something in the family. And my daughter's an oncology genetic counselor and explained to me how being in the family doesn't necessarily mean inherited. It could mean you've grown up in the same toxic environment as everyone else. So perhaps radon or asbestos or something else, or maybe something none of us even know about yet because there hasn't been enough, research going into lung cancer, as, tobacco use has been, basically labeled as the only cause of lung cancer. You use this word normalizing. I think it's very important that people understand that this is a cancer anyone can get. Yes, there are risk factors. We want to be aware of them, mitigate them, or, eliminate them if possible. But for those of us who don't fall within this, how do we get screened? Pierre has spoken to me with his hat on as a primary care, and he said, if a patient expresses a lot of anxiety to me about, gosh, I think I, should be eligible because my mother had this, and there was high radon in the house, and another family member had this, an aunt or an uncle, that it's not against the law for a physician to refer you for this screening. That doesn't mean you're asking to be in a lung cancer screening program where you're getting screened every year, but at least in that moment of time. And then it's going to be up to you and your team to figure out what's your comfort zone. Where do we go from here? If something isn't found, do you do this, every 5 years? What do you do? And of course, our hope is always, for research funding along the spectrum of unmet needs here, is that we come up with a better tool. Maybe a tiered tool. Like, for example, if you have a family history of breast cancer, you're screened earlier than age 40. Here, maybe, I hope there'll be something, that gets developed with a blood test or urine or saliva or something that kind of then raises a red flag that, you have this risk factor. We see something shedding in your, tissue, in your blood. And those people then go on to the next level of perhaps the screening. Because again, if it's true that the medical community is validating this, anyone can get this, we need some sort of universal tool.
Well, and I like the example you give of radon. And for those who don't know, radon is another cause of lung cancer. It can come through basements. And maybe, do you know the dose of radon that one needs to be exposed to to be eligible for lung cancer screening?
I don't know that that is even a criterion yet for lung cancer screening. I know,
Exactly.
yeah.
So we have these factors that we know are associated with
And we had
cancer,
nothing, yeah.
and we just, as a medical community, we don't know what to do about it. So it's not that more people, like, we haven't figured out everyone who needs to be screened yet.
Right.
So we work together. We use tobacco because it's something that's heavily studied. But keep in mind, we mentioned that the criteria is like 1 pack per day times 20 years. And the way we calculate that is frequently the maximum number of packs per day you smoked. So let's say over the last 20 years, you were a casual smoker, meaning that's the term we would use in the chart. Meaning, you had a cigarette after dinner or 2 or 3 a day. But 4 years ago, you were a pack a day for, a year. We would still call you a 20-pack year history. So it's very imprecise. And then that's a challenge, because we're trying to do science around something that's really hard to quantify. And we do our best, but the screening guidelines are the best we can do with limited tools. So they're not done.
No.
We're missing a lot of people that should be included.
And what's interesting is the EPA has a standard, though, for what's actionable in your home. So think about it as you get your screenings for cholesterol, blood pressure, mammography. Don't you want to screen the environment that you're living in and raising your family in? And so their actionable level is 4.0 picocuries of radon gas. And anything above that or above, it's actionable. So if you're below that, I mean, some people, like my son, who's an environmental engineer, goes by the World Health Organization standard, which is 2.7, and he wouldn't move into a property unless it was lower than 2.7. And that is something you could mitigate. But how long were you exposed to that? Is that number fluid? Does it change? It does change. So it's hard, again, to quantify what that is. And so the best tool we have to get screened on maybe not a screening program, but in a diagnostic level, is your own voice expressing those concerns to your healthcare team, and also knowing that you will have to pay for this. Your insurance will not cover it.
Yeah, and I think we focus and research a lot around things that improve quantity of life. We do a really good job of that. We have these big studies, and we're able to look at, does this thing that we do, this intervention, on average make people live longer, or does it not make people live longer? And that was a big part of these big screening studies. And we see, they actually do live longer. Now, one example I like to give is we have a pretty big infrastructure around anti-anxiety medicines, antidepressant medicines. So we do agree that your quality of life kind of matters. And sometimes if you've been exposed to radon, if you have a strong family history of lung cancer, and you're appropriately concerned that you're at elevated risk, well, that peace of mind isn't worth nothing. That matters, I think. So I think advocating for yourself, even if you don't fit these criteria, is worth doing. The peace of mind alone can be worth the money.
Yeah, it's very important. And I'm really glad as a provider you mentioned that, because a lot of times patients don't feel that their providers or a physician scientist who doesn't see as many patients may look at us as just a point on a data graph. But we're human. Every point there is a human story and its ripple effect. So that is such an important statement. They need peace of mind. They need that to move on with their lives. And we don't know what that looks like, though. We don't know how frequently it is, but we do know we have some power to advocate and, do what we can to best protect ourselves.
Well, and along those lines, the balance is important between screening the people that will benefit, but probably not screening everyone. Lauren, can you speak to why we don't screen everyone with a low-dose lung CT?
Yeah, I mean, so just kind of reiterating what you guys mentioned earlier, the screening guidelines as they're written are imperfect. We know that even among people with a smoking history, there are people who are not eligible, who are high risk. They end up getting lung cancer. The American Lung Cancer Screening Initiative has published some really important studies around this, showing that actually duration of smoking, how long you've smoked, is actually maybe more promising in terms of actually capturing who is at highest risk compared to pack years. And to your point, pack years can be very challenging to calculate. I mean, no one comes in saying I've smoked a pack a day for 20 years, right? Most people change how much they've smoked over the years, and it can be overwhelming for your provider to try to estimate that. We are kind of beholden to the data, right? It took 2 large randomized controlled trials. Even after the NLST was published in 2011, even the American Academy of Family Physicians wasn't really on board. They did not endorse lung cancer screening with low-dose CT. The United States Preventive Services Task Force first published guidelines for lung cancer screening in 2013. And then it wasn't until the Nelson trial was published when people said, okay, lung cancer screening with low-dose CT, it does work. And, everybody kind of was like, all right, it became accepted. And but it's a newer screening modality. Now we are seeing these changes in epidemiology around lung cancer, right? We are seeing people like Heidi, who have never had a smoking history, who get lung cancer. And we need to figure out why. And that's the whole point of understanding who should be screened and how often, right? Does somebody like Heidi, maybe if she was exposed to radon, if she has a family history, should she be screened every year, or should she be screened every 2 years, or is it every 5 years? I think we need clinical trials to figure this out. We also need to consider other risk factors outside of smoking, because this is the way the epidemiology is going. And what I mean by epidemiology is who is getting lung cancer and at what age they're getting it. And so some of these studies are starting to come out, right? The female Asian never smoker study, FANS, that's run out of NYU, and I think, is it UCLA? I forget. And then the talent study that was published in Taiwan, where they screened a lot of women. So in particular, women of Asian descent are at, seemingly high risk for lung cancer, no smoking history. And so there are sort of 2 schools of thought there. Some people say that the lesions they're finding, these nodules, are very slow growing, very indolent lung cancers. They won't develop into an invasive lung cancer for years to come. So we are overdiagnosing. And so that's the trade-off, right? Still, these are stage 1 lung cancers. Some could argue, based on the data that we have, that there is a benefit. In the talent study, women who had never smoked had a higher rate of lung cancer than men who did smoke. Those were the findings. And yet we're all still kind of very slow to decide whether or not we should still screen other populations outside of smoking. So I think we'll get there. I know, to people who, like you, I'm sure you're like, when are we getting there? And I get that. And I feel the same way, as someone who advocates for screening and try really hard to weigh the risks and the benefits. And I see people who were failing, and it bothers me. It keeps me up at night.
Yeah, and I think that balance of, if you screen everyone, you're going to find a lot of things that never needed to be found.
Yeah.
People get biopsies they don't need, anxiety that they didn't need to have, and they have to come back for more scans.
Yeah.
You want to follow things over time. So there's an economic cost to the institution, like of healthcare. There's the cost to the patient, their time away from the other things they're doing, the anxiety around the biopsies. And then this question that I've struggled with a little bit, where we're catching people with small tumors, and we don't know that those were going to become problematic. If it were me as the patient, yeah, take it out, of course. But there may be tools in the future that help us differentiate. Is this something we can just watch, or is this something that we appropriately acted on and removed? With the tools we have now, I think there's no other choice. If you put a needle in that and it comes back cancer, like, let's get it out of there. If the costs and the risks and benefits are appropriate for the patient. but it's challenging. Our tools are still limited. Not only are we limited in who we're including in scanning, but what we do with the results is not yet totally hashed out.
Yeah.
Yeah, and that's where I think the patient voice becomes very important, because we should be able to make our own informed decisions.
Mhm.
So it may not be fun, maybe quite unpleasant to have a lot of uncertainties around, but if I could turn the clock back and let's say I was eligible for screening 7, 8, this thing probably I was walking around with it for my guess is a couple of years before. So we turned the clock back and I was being proactive in my health, getting everything else done. And I could have had this, and it would have been maybe something very small at that point. It would have been my decision. What are we going to do? Are we going to watch and wait? Are we, but it's monitored, right? And then maybe if we saw it changing, we would say, you know what, let's go after it now. But to not even be part of that conversation, is very difficult for people in this part of the community that don't have the primary risk factor.
Yeah.
So it's empowering for patients to be able to, even though it's not fun, it's like, oh my gosh, now I'm thinking about this a lot. Now I could be walking around with this, or I could be walking around with nothing. What do I do? What do I do? But we could then have a systematic way of managing it with our teams.
Yeah, and like you mentioned, for someone who may not meet these eligibility criteria, which, functionally for us means insurance isn't going to cover it.
Right.
It's not illegal to get the scan done. And there's a lot of reasons to evaluate for something that the Center for Medicaid doesn't agree with. They're coming at it from a population-based standpoint, but that means nothing to the individual. Like, your life and your risk factors may not be in the bucket of, how do we take care of 300 million people?
Right.
Yeah. And now, even thinking about the current guidelines, like 80 is the new 60. People are just living longer. And I've seen people who decide, even though they're no longer eligible past the age of either 77 if they have Medicare or Medicaid, or 80, right, if they have other types of insurance. And sure enough, they just decide to keep paying out of pocket and they develop lung cancer. I've seen this before. The average cost without insurance, it's around, somewhere between $200 to $400. That's not an insignificant amount of money for people. And even people who are eligible and insurance covers lung cancer screening with no cost sharing, it should now, right? We're still seeing subsequent out-of-pocket costs for follow-up scans, for follow-up testing, for biopsies. I know New York State just passed, the Senate and the House passed legislation to actually mandate that insurance cover those subsequent imaging studies, workup, et cetera. But we need to get everybody on board, right? The cost is absolutely prohibitive for people. They're like, well, I don't want to go to the doctor anyways, and I definitely don't want to pay for it.
Yeah.
Right. So,
no, I think there's a lot of factors that go into what, the barriers. There's a lot of barriers right now, but one of the things that I think is kind of on the horizon is changes in how we're doing our screening. For most screenings, we have a radiology test. Colonoscopy is a little different. Cervical cancer, we have a swab. But for a lot of the stuff, for mammogram, the lung CT, we're talking about radiography, and we're getting tools now that should make that more effective. One of the things that I'm excited about is the implementation of AI tools to help, improve the quality of our reads and how the scans are interpreted. But then you also mentioned these blood tests. We have blood tests that are in the pipeline, we're working on them, that are probably soon going to have the ability to say that we think there's a cancer in there somewhere. Now, I'm worried about that because I, as a provider, I see the situation coming up where, hey, the blood test is positive. We did a scan. We didn't see anything. Enjoy your week. That's not going to be a fun time.
Right.
So we have these exciting things, but it's going to get better, but it's not there quite yet. And it'll take some time.
It will. And funding. And so,
Mhm.
yeah, and funding doesn't happen without awareness. And because
That's
if
it.
people don't know it's out there, they don't care about it. So, you raise the level of concern, the funding usually comes.
Yeah, I think a lot of groups have done a really good job with this. The breast cancer community has done a great job with this. Lung cancer's catching up.
Yeah, we're getting there. I mean, you mentioned barriers, right? And I do want to sort of convey to the audience how low our screening rates actually are with lung cancer screening. So on average nationally, people who are eligible to get screened for lung cancer, among those who get screened, it's around 16% of those who are eligible. Compare that to something like breast cancer screening, where around 80% of women on average who are eligible for breast cancer screening are getting screened. So the good news is that we have a lot of room for improvement, but the bad news is we have a lot of room for improvement. And I think awareness is huge. I mean, a lot of the work that I've done has really been on exploring barriers to lung cancer screening and in different contexts among different people. And what I've realized is that there are barriers at all levels. And what I mean by all levels is the patient, provider, and health system, or just system level politically in general. And they are all interconnected. They all influence each other. So, for example, these can be things like structural barriers, like how is the patient actually getting to the appointment? Can they schedule the appointment? Are the radiology scanning hours or imaging hours within, is it 9 to 5 and they're working and they can't actually get away to get a screener, right? I mean, maybe they need to be screened on weekends or after hours. So things like wait times. I mean, people just don't have, they have other priorities. They have families to take care of, or maybe sick parents, or whatever that might look like. And then, of course, I think insurance coverage is getting better. We are getting there. But again, if you're not covered, or you don't have insurance, or you're underinsured, most people are not paying out of pocket for this test, or they're not paying out of pocket. Then, they don't want to pay out of pocket for subsequent scans. And getting to the awareness component, this is just not something people are talking about. A lot of times, a lot of providers I've talked to are like, to be honest, people come in, they ask for their mammogram. They're like, I turned 40, I'm ready for my mammogram. Like, let's go. And patients just aren't asking about lung cancer screening in the same way that they're asking about other cancer screenings, or they have other priorities, right? They have other concerns, and providers have to address those, and they just kind of forget to ask about it too. And the other thing is like, okay, if you don't ask your patient, if your patient is 40 and they're a woman, you're like, oh, shoot, I forgot to tell them that they're due for a mammogram. If you don't get their smoking history, if you haven't calculated their pack years, well, it's a whole lot harder then to go back and get that information to figure out if they're eligible. So this is something that really just needs to be front of mind for everybody in every context, whether that's a conversation with your family member around the table, so that when they go in to see their doctor, they are asking like, hey, am I eligible for this? And maybe they're not, right? But they're asking about it, and we're getting the word out, and we're just making this a part of your normal care.
Well, and part of that is you are championing Lung Check. Yeah, maybe you could speak a little bit to your initiative.
Thank you. So Lung Check is my baby. It came out of work that I did actually very similarly, that probably overlaps, with work that Pierre is doing, where I realized kind of how low our screening rates were. And I figured a really good place to start might be with primary care physicians, because of the position that they're in and how integral they have been in terms of tobacco treatment and smoking cessation and the relationship they have with their patients. And so I wanted to create something that was a go-to guide for patients and providers, that provided high yield content that was easy to navigate, and kind of helped providers step by step understand why this is important, who's eligible, what do you need to document in somebody's chart, even for insurance companies to say, okay, your patient meets criteria and you documented everything and we're going to approve this, right? And then, what are the billing codes? What does shared decision making look like? And what do you need to talk about? What does smoking cessation look like? What do you need to talk about? Where is the nearest screening facility? All of this is available on our website. And then we also kind of explain, well, what do the results mean? And we do this for patients. We do this for providers. Obviously, it's a little bit different, we depending on who our audience is. But the idea was really to kind of address a lot of the barriers that I found when I talk to people, who are involved at any level of the screening process, and to say, like, we're here to help. This is a resource that hopefully you can rely on, and doesn't start with really negative kind of doom and gloom messaging, right? And is inclusive. And also, one thing that I get a lot from people as providers will say, a lot of my patients say, well, I'm still smoking and I'm going to get this test when I quit. Or patients will say, like, oh, I quit smoking, I don't need this test, I feel fine. And the point is, I try to address some of that and say, whether you quit or you're still smoking, like, this test is beneficial for you if you're eligible, because we can face this head on. There are treatment options. There is hope. Heidi is like, the poster child of hope. And so I want them to picture her face whenever they think about this or they're afraid, And so, lungcheck.org, I am, it's a work in progress, and I always welcome feedback from anybody. It's always evolving, but I'm proud of the work that we've done so far.
No, and
It's amazing work.
for people there too. It's a great website, and the whole initiative has been really impactful, as has the White Ribbon Project. Heidi, can you tell us a little bit more about that?
Yeah, I never dreamt that my one burst of anger and one ribbon would have led to a movement in lung cancer where people are literally, I think, identifying with the fact that they have a symbol now, there's something, and they're worth it. Their stories are worth listening to. They are not people who should be discarded or ignored. This is the number one cancer killer. It doesn't have to be. And we do see a shift changing. We used to say it killed more people than breast, colon, and prostate combined. That's no longer the case. It doesn't kill all, more than that. So now I say, well, it still kills more than breast and colon combined. And we want to see those rates go down. And the way they're going to get down is with more awareness, people talking about this, not blaming victims of, a tobacco industry, or people could even say, well, your radon was high. You should have known better. I mean, we can blame about all kinds of things. That's not productive, and
Right.
It's not in anyone's best interest, considering the ripple effect of a disease on a family. And now, as you talked about, Dr. Groner, there's this uptick in young non-smoking women. Many of them have young children. I mean, the ripple effect is more like a tsunami. I mean, this is very difficult to navigate, and it doesn't have to be this way. And especially, look what we have here. We have two very young, passionate healthcare professionals that are advocating for better for us, and they're on our team. And with that, getting now the general population to understand that this is an issue, I think we can learn so much from successful movements like the breast cancer movement and HIV/AIDS, and we can turn this around. We have seen great progress even since I was diagnosed 7 years ago. I was given over the phone this dismal prognosis, told maybe I had a 6% chance of living 5 years. Now I see that overall survival rate is up to about 27%, which is still a very low number, but we're headed in the right direction. I mean, we can do this. We're just going to keep going. We're going to keep going.
For any patient who is apprehensive about getting a low-dose lung CT, Lauren, what's a piece of advice that you would give them?
I think the best piece of advice is that this is a test that is quick, it's painless, it's not invasive, there is no prep needed, and there are resources out there to help you get scheduled and to help you get screened. And this really is, lung cancer screening really is your best chance of living a lung cancer-free life. We are here to help, and I think, don't be afraid to get screened. Be afraid not to get screened, because there are so many people who want access to this test who aren't yet eligible. And so it's such a valuable tool that we have. And if you are eligible, please get screened, because it is something that could actually save your life.
Yeah, well said. And Heidi, what would you say to someone who's on the fence about getting lung cancer screening?
I would say things in lung cancer have changed dramatically. There's great hope today. Get screened. if you get a mammogram, that's a lot harder and more uncomfortable and difficult than
I confess.
than a CT scan for lung cancer. Again, there's nothing invasive about it. You get to keep your clothes on. This is done in 2 to 3 minutes, and you get some valuable information, and you can live a very high quality life, even with a lung cancer diagnosis, and you have a great chance of doing better than me because I was caught late.
Well, that's ending out some optimism for the future, which I completely agree with. Thank you, everybody, for watching today. Again, this has been Cracking Cancer. You can visit us at crackingcancer.org. And remember to like and subscribe for more accurate information from experts and patients. Okay, thanks, everyone.
Thank you.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.